Welcome. Thank you for joining us to look at research on adaptive seating. Please contribute comments or questions on the YouTube chat and I'll respond after the webinar. As we know, the systematic review is considered the highest level of evidence. Articles in a review have been critically evaluated and only studies that meet the criteria are included. The researchers may assign a level of evidence to each article included in the study. We are familiar with the GMFCS, developed in the late 90s. Research before that time won't identify research subjects with these levels. Level 3 children have a loss of that ability for direction-specific adjustment for a sitting posture, particularly when they are using their arms to reach. Their intrinsic ability to modulate muscles to control arm movement is more limited. Their bodies may compensate, and certainly they have to give attention and energy to the task of sitting and controlling arm movement. Then, 40% of children with CP are at levels 4 and 5. These children clearly have deficits and dysfunction in direction-specific adjustment of postural muscles for that ability to maintain the center of gravity over the base of support when sitting. We'll start out with looking at available research on these aspects of sitting ability. Here are 4 adaptive seating interventions studied for their effect on sitting postural control. I won't read every detail here. You can come back to this information on the handout for your own reference. We noticed that not many articles actually qualified for inclusion in these reviews. The studies discussed in the next slide were in these reviews about postural control and adaptive seating. Some of the beginning research in adaptive seating was with the so-called saddle seat. This placed the child's legs with abduction, outward rotation of the hips, and an anterior tilt of the pelvis with midline trunk posture and equal weight bearing through the lower extremities. For children with cerebral palsy, when placed on saddle seating, findings showed that trunk and spinal extension was increased. Again, these details are available for your reference. Notice that the research is from more than 20 years ago with small numbers in the studies. 2 of the studies were assigned a low level of evidence in the 2008 systematic review by Julie Chung. However, we do conclude that the saddle sitting position promotes trunk extension. Naturally, we immediately think that more back extension is better, but this 2001 study looked at erect versus crouch sitting for children with spastic diplegia, challenging their sitting balance on a movable platform. The children actually showed better modulation of their posture while in their typical crouch sitting position. The second study in 2005 made the observation that reaching quality was better in the crouch sitting position. I'm not promoting a kyphotic posture here. It's just a reminder that each child's postural solution is the outcome of a dynamic interplay of their intrinsic body function, their own past experience, and the environment task context. No adaptive seating involved here, so these are not in those reviews. That brings us to a discussion of the functional sitting position. These 3 studies in the early 1990s looked at children positioned with symmetrical weight bearing on their ischial tuberosities, their hips were fixed with a belt, and their thighs separated by abduction orthosis and footrests. Notice that the line of gravity of the upper body is anterior to the axis of rotation at their ischial tuberosities. They are sitting with seat level or an anterior tilt and have a table or tray. What were the findings? Improved postural control. And here are the details available for your reference. Notice that the 3rd study, published in 1995, was actually a 5-year follow-up. The children who discontinued use of the functional sitting position actually deteriorated and showed worsened trunk control. What about seat surface inclination? The research shows varying outcomes. It does seem that a 10-degree anterior tilt may improve back extension. More details. Please go to your handout to see it all. But what is interesting is that with the second study here, moving beyond to 15 degrees of anterior tilt results in increased extensor tone of the back, along with less variability of movement of the head. So the research recommend 10 degrees of anterior tilt as being beneficial. With the third study, notice that the posterior tilt improved lower limb stability, which is interesting. Now we'll look at the research on dynamic sitting. This study by Simolin in a 2015 review showed that the dynamic backrest enabled better positioning of the pelvis. So the children did not slide down in the seat, but also their upper limb coordination improved, which is remarkable. Those same findings were borne out with the 2010 study with the same seating device. The trends with the hand study are also interesting, though not statistically significant. Now let's move on to look at research on adaptive seating and upper extremity function. Here are 4 adaptive seating interventions studied for their effect on arm and hand use. Some of these articles we've already mentioned earlier. We have these systematic reviews as well, which all include mention of adaptive seating and upper extremity function. You can certainly come back to this again on the handout for the details. We described the saddle position earlier. Interestingly, these studies showed no measurable effect with this position on upper extremity function. We also discussed the research on the functional sitting position earlier. These studies did show improved arm and hand use with this position. And what about anterior tilt versus posterior tilt? It simply is not so easy to make generalizations from the available research. This 1987 study actually showed best performance for spastic subjects at a horizontal level seat position. The 15-degree anterior tilt impeded performance for children, specifically with athetoid CP. And then the next study showed no significant difference between positions. The 1999 study was with children ages 3 to 18 months, and for these infants, the semi-reclined position resulted in more activation of those muscles involved with reaching. Here are additional studies that were not included in the systematic reviews. These studies suggest that there is a difference in response to seat position between children with unilateral CP versus bilateral CP, and that more postural instability may occur with reaching from a posterior tilt position. You can certainly come back to this to capture all the details of this information here, but these researchers were evaluating reaching tasks in a variety of sitting conditions, and the first 2 studies show differing results between unilateral and bilateral cerebral palsy. It seems that the children with unilateral spasticity certainly benefit more with an anterior tilt than do those with bilateral spasticity. The third study does not specify the CP type and concludes a benefit with anterior tilt overall. This 2017 study also looked at arm control, comparing a standard chair, adaptive seating system, and custom-made orthosis. Both the adaptive seating and custom-made orthosis showed significant improvement over the standard chair. However, there was no difference between these 2 interventions looking at data of the entire group of 20 subjects with the sitting assessment scale. Now we'll discuss segmental control. Segmental control is a specific method of providing support at varying levels of the trunk, from full support at the level of the axilla to systematically reduced support down to the level of the pelvis. This assessment enables a new perspective on the treatment of deficiencies of trunk control because it offers a level-by-level assessment and treatment approach for practicing and gaining trunk control. SATCO begins with a segmental assessment of trunk control the evaluator progressively changes the level of trunk support at 7 distinct levels, beginning from a high level of support at the shoulder girdle, which allows an assessment of cervical or head control, then support at the axilla to assess upper thoracic control, and then at the level of the inferior scapula for a mid-thoracic control, at the lower ribs for lower thoracic control, and below the ribs to assess upper lumbar control. Finally, the pelvis assesses lower lumbar control, and then no support, which of course measures as full trunk control. So what is exciting about the evaluation tool is that it assesses more than one aspect of postural control. Your static or steady state control, and then that active anticipatory control, as well as the reactive control where you are maintaining or regaining your trunk control following a threat to balance, for example, a brisk nudge. So this study, published in 2016, shows that for children with mild cerebral palsy, the level of support had no effect on posture or reaching. For those with moderate CP, when support was only provided at the pelvis, they did not do so well as when support was provided at higher levels. For those with severe CP, they did best with support at the axilla. So in their case, any support at mid-ribs level or lower showed a worsening of their ability for reaching tasks. So for children with CP, we know that their postural ability to fine-tune those direction-specific adjustments to task and environment conditions is impaired. And this research shows that they may achieve reaching tasks with more success when the external support is provided and aligned with their intrinsic level of trunk control. So now we have discussed sitting postural control and upper extremity function. That brings us to head control, which we know is important for feeding, eating, speaking, communication, certainly reaching, which requires eye-hand coordination. Here are seating interventions studied for their effect on head control. Only one of these articles was included in the systematic reviews, the Tilton Space article. In 1993, Angelo looked at one 9-year-old child with cerebral palsy and the effect of 2 different posterior tilt positions on the child's head control. The finding was that a 15-degree posterior tilt showed improvement when compared to horizontal. This is a low-level study involving one child, and it covered a time span of 10 weeks, and measurements were done in the classroom environment. On these next 2 slides, I've included studies with segmental control. The findings here showed that children with spastic cerebral palsy had more head sway with their eyes closed, which indicated that they relied on the visual input along with the vestibular and somatosensory input for their sitting postural control. Children with dyskinetic CP, on the other hand, had better stability with their eyes closed. To me, that indicates that they had a strategy for intrinsic control that for some reason was more successful without the visual input. And here's more on segmental control, so you are invited to come back for all the details which are available for you. Essentially, this first study concludes that the level 4 children showed no difference in head sway between the different levels of support, which indicates that they had developed an intrinsic motor ability to stabilize their head during quiet sitting. The second study showed that when very high levels of support were provided for level 4 children, this actually worsened their head control, suggesting that too much support may interfere with a child's own control of their postural sway. This 2018 study is with the head pod, which gives support to the head while allowing for neck rotation. The study began with 14 children, although not all stayed through the full 6 months of the study. And in that time, there was significant improvement in the ability of these level 5 children to actively maintain an upright position of their head. If we think about it, sitting is an activity. The ICF defines an activity as the execution of a task or action. For able-bodied people, sitting is not passive. It is a combined, continual process of muscle control that is anticipatory and preparation for movement, reactive, regaining balance or correcting. Even in quiet sitting, there is a small amount of postural sway present. With the dynamic systems theory, we recognize that much of this control occurs intrinsically at a subconscious level. This list here of articles offer good insight into postural control. In normal development, infants will actually begin by gaining head control, so important for vision. Reaching and arm movements may be somewhat random at first, but as soon as reaching and grasping occurs, there is that necessity for those postural adjustments modulated to the task. This direction-specific postural activity actually starts at a very young age. Then there's the higher level capacity of modulating the amplitude of muscle firing, the sequence based on proprioceptive and other input, so as to successfully interact with the environment. And in normal development, this aspect of postural control also begins to emerge quite early, before age 1. This postural and movement control is continually refined as the child then learns to reach and later to sit and then reach from that position. None of this is pre-programmed. It is situation-specific, and the fine-tuning is based both on prior experience and on in-the-moment input from visual or vestibulary or somatosensory systems. So the recruitment order of these muscles for that direction-specific adjustment is highly variable throughout childhood. Now, for our children with cerebral palsy, there is a deficit in this area of postural control. For example, in some children with CP, the neck muscles may consistently be activated before the trunk muscles. That might be a compensatory strategy to assure head control. Or we may see an excessive degree of antagonist muscle coactivation, which may be a strategy to prevent overbalancing, particularly when in the standing position. We certainly see difficulty with efficiency in reaching. That's due to lack of muscle coordination or fine-tuning adjustment of muscle firing for posture and arm movement. And that may be due to deficits in the sensory input pathways or deficit in the pathways for programming those muscle postural motor synergies needed, or a combination. Another example is that increase in trunk sway that we see with these children that is a combined movement with their reach. And that might be their way to make up for weakness or control of the arm and hand, or it could be due to decreased ability to control the trunk, or some of both. In her 2005 article, Eva Karlberg in Sweden suggests that for children with CP, we can provide support in sitting to decrease the degrees of freedom that the child has to control, and thereby enable them to achieve tasks that would otherwise challenge their postural control. The support can then be gradually decreased to a level the child can cope with as they continue to practice and learn. Another suggestion she has is to intentionally restrain the trunk loosely in the adaptive seating, so the child perhaps begins the attempted reach with a combined arm and trunk motion, but in order to reach the desired object, would then necessarily move the arms separately and distinctly from the trunk. In this case, we are partly stabilizing or restricting the trunk to enable free arm movement. In the Move reference manual, Linda Badabi alternately suggests providing a stabilizing surface for the arms to allow practice of head and trunk control while the child is observing an interesting environment. We do not want adaptive seating to only substitute for the postural control that the child lacks, but to be used as an intervention to provide practice and learning opportunities for the child to gain the ability to sit. Certainly more research is needed in this area. Here is a visual diagram of the International Classification of Function, which is the World Health Organization's current framework for defining health. Central in the diagram is activity. For example, the ability to sit, to use arms to reach, to maintain head control to see. On the left is the child's intrinsic body functions and structure, and the level below activity, and that may be impaired. On the right, the level above, is participation. That's the child's involvement in the real life environmental context, which may be restricted. Then there's the contextual factors of the environment, such as adaptive seating is in the environment, or the personal factors such as the child's motivation and their personality, and these are very important to take into account as well. So our consideration of research on adaptive seating as an intervention reaches below and beyond the level of sitting as an activity. Notice that there are two terms related to activity: capacity and performance. Capacity is a child's abilities in a defined situation apart from real life. That is, the intrinsic ability of the child to perform a task or action without any environmental supports. So this relates to their body functions and structures. We'll look at 4 areas where there has been published research on body functions and structures. For any of the references I'll mention, you can find links to abstracts or full text online on the downloadable reference list. And where these have been included in systematic reviews, that will be noted on the reference list in brackets. Let's look at the effect on muscle tone recorded with electromyography with these 3 adaptive seating interventions. We've already looked at the research in the early 1990s looking at the functional sitting position. This 1993 study by the same researchers showed that the tonal activity in the lower extremities was lowest with abduction of the legs and a horizontal seat surface or forward lean seat position. This 2002 study took EMG recordings of 4 children with spastic diplegia between 3 and 8 years old of age while in the functional sitting position with or without the hip orthosis that was used in this study. There was no significant difference in EMG. Although from the 1980s, these studies are still relevant, the 1983 study trialed 7 different combinations of seat inclination and backrest angle and found that the horizontal position relative to gravity decreased tone. The precaution here with the 1986 study is that the reclined backrest position may increase tone. So when a position of rest is needed, use posterior tilt in space rather than recline, which may trigger extensor tone. Here are 2 studies that discuss scoliosis. All 16 children and youth in this study, with the average age of 14.7 years, had spastic tetraplegic cerebral palsy. All 4 limbs were involved. As you can see, one phase of the study was to take one of the bilateral supports at the axilla and move it down to the convex side of the curve at the thoracic level, and thereby create a 3-point force system to counteract the curve. The bilateral supports at the pelvis stay where they are. During a 10-second measurement, this position did result in static correction of scoliosis and improved posture. This 2015 study was with a 6-year-old and a 9-year-old, both with PVL, periventricular leukomalacia. They used the I2I, which is a cervical support from the shoulders to the lower portion of the occiput, while still allowing head movement. There was measurable improvement to spinal alignment over time in the case of scoliosis. Now we look at research that focuses on skin integrity. First, a little background on pressure injury. Skin damage can result from prolonged pressure, moisture, or pulling forces along the skin. An example of shear might be when a child is sliding down in their seat and then is stuck or is pulled further along. Some of their skin is held back and some is pulled forward. Skin damage does not only depend on the magnitude or duration of the load, but also on that shear force present. If skin is being pulled at the surface, then the amount of load needed to trigger tissue damage is cut in half. In her 2017 webinar on tilt and recline in pediatric mobility products, physical therapist Missy Ball points out that chairs with a fulcrum near the anatomical hip axis work best for preventing shear forces when moving in and out of recline. As a normal backrest reclines, the client slides downward and the relationship of client to seating components changes. This effect of shear can be lessened with the fulcrum of the backrest located close to the axis of the client's hip. This study measured the body-seat interface pressure in 4 positions typically used for pressure relief. This was with children ages 7 to 18 with spina bifida who had complete paraplegia. All these positions reduced pressure compared to being in neutral. The Michael 2007 article is a systematic review that concluded that posterior tilt of 20 degrees or more provides pressure relief. The 2011 study with adults with spinal cord injury concurred. A 15-degree posterior tilt did not actually change pressure at the ischial tuberosities. Fortunately, blood flow did increase with all tilts from the upright position, so small tilts do also provide some benefit. The 2001 study with able-bodied adults determined combined tilt in space and recline had the most pressure relief. Let's underline the difference between backrest angle and tilt in space. Moving the backrest to open the seat angle creates a recline. Closing the seat angle reduces the angle of the hips and supports a forward lean. We know from research that a reclined position can increase extensor tone when the seat is horizontal. Expert opinion suggests this may also contribute to shear forces on the skin. Tilt in space may be posterior or anterior. Research tells us that posterior tilt provides pressure relief and that anterior tilt contributes to active back extension. Anterior tilt positively affects breathing as well, as we'll see later. Effect on upper extremity function is less clear. The forward lean position may be achieved with a closed angle of the backrest or with an anterior tilt of the seat, or both. Ginny Payleg, PT, in her 2014 presentation at the Conference on Exceptional Children, suggests combining backrest angle and tilt in space to find the optimal position. She suggests a first recline to open the backrest angle until you have the hip angle appropriate for the child, and then do tilt in space, moving the child until you have the optimal line of gravity to promote the child's postural position. Hip flexion can place the child at risk for contractures or hip dislocation, so this open angle at the hip, together with the abducted position of the hips with slight external rotation that is recommended by current postural management, is more recommended when feasible with the child. The 1984 study shows that combining anterior tilt in space with an open angle at the hip does not in itself make a significant difference to upper extremity function, although the children did not find that position uncomfortable. This research looks at adaptive seating's effect on respiration. This 1986 study shows that children with cerebral palsy in adaptive seating had increases in the respiratory measures that you see below on the slide. I have put the definitions there, so those are available for those interested. These may have implication for speech as well. Okay, here are some more measures. Take a moment to heave a big sigh. That is not your tidal volume. Your tidal volume is your normal breath amount during normal breathing. What you see here are measures of normal daily breathing. The exception is the forced vital capacity, which is the forcible exhale of your largest breath, like you do if you're really annoyed, right? I think we've all been there. Research with children with spastic cerebral palsy shows that an anterior tilted position improves these respiratory measures. These studies were with 6 children and with 16 children, respectively. Back to the ICF. In this 2007 article, therapists specifically focused on adaptive seating effects on body function and structure. Meanwhile, parents concentrated on personal and environmental factors. What matters most? How about participation and performance in real-life context? Performance is the child's interaction with the environment. Participation is closely linked to performance. As we know, the environment may support or may hinder the child. Let's look at the research on participation. These are areas of participation for which we have research, although truthfully some of these assessment measurements may have been taken in a defined situation apart from real life. None of these studies met the criteria for inclusion in a systematic review, but they do indicate that adaptive seating has a positive effect on speech, particularly when the child is not in a semi-reclined position. This first article, I would recommend that you check out the abstract. This headpiece was gradually faded out by cutting away sections of the foam rubber until the child achieved self-feeding. So the reflex was overcome through preventing the adverse movement and through practice opportunity. The other studies show the benefit of postural support during eating and feeding. These single-subject research studies showed improvement with alternative augmentative communication device use by these individuals when their seating position was adjusted as described by the researchers, so there was benefit. In these studies by Ryan and Rigby, parents reported that their young children with cerebral palsy engaged in self-care and play when using adaptive seating in their home, such as adaptive toilet seats, and their child's activity performance decreased after these were removed from their homes. The Pope study was one of the studies we looked at on the saddle position. 3-year follow-up showed improved activities of daily living. These children with spastic quadriplegia or diplegia were between ages 1 and 5 and showed a marked improvement in their ability to perform fine motor tasks. So they achieved higher psychological test scores with adaptive seating. This first study was with 4 infants, ages 9 to 18 months, who benefited in social interaction with use of a contoured foam insert. The second study from India states that the greatest benefit of adaptive seating was social interaction. However, as Julie Chung points out, we need more ways to effectively measure these benefits. In conclusion, this overview of 5 systematic reviews published between 1998 and 2008 concludes that it's not responsible to create broad clinical guidelines based on the current evidence. A lot of what we have is lower quality studies with a lack of appropriate outcome indicators, or mixed characteristics in the population, or a lack of clarity describing the intervention. So more research is needed. Please step up. As encouragement, let's remember that expert opinion and clinical judgment do have a role in practice. So next, we will actually be doing a demonstration of the Rifton activity chair, and that will be aired a week from today. So that will further discuss functional sitting. Until then, check out these resources that provide seating recommendations, and please join me again in a week for that demonstration portion. And thank you for your participation.